Thank you very much for inviting me to speak today. I'd also like to continue our welcome to Manchester. Despite the rain today, we might have a bit of sunshine in the afternoon, so hopefully it'll be a glorious day nonetheless. Also like to thank the Psoriasis Association for funding some of our work. We have 3 PhD students funded by the Psoriasis Association, 2 of whom you'll hear from today, 1 of whom has finished and have published their work imminently, and it will be delivered at the BAD conference to doctors in a couple of weeks' time. So a lot of great work happening. So thank you very much for your support of this research. So my title is Increasing Understanding of Biologic Treatment and What's New from BADBIR. And I hope you've heard a little bit about BADBIR, but I'm going to go into a bit more detail about this research project. These are my conflicts of interest. BADBIR as a project is funded by the BAD, but also receives income from multiple companies. So before I start, I'd like to have a show of hands. How many of you have participated in a randomized controlled trial? Perfect. So not that many of you, so hopefully I can say whatever I want about them, but you'll know a little bit about the experience of participating. And actually, randomized controlled trials are fantastic research projects, essentially. They really come from the simple idea that randomizing, throwing the dice, means that you can have 2 groups of people who are balanced in terms of how they are. So it's a fair comparison. And so then you can test the effect of drugs afterwards and have a good understanding of how well they work. So they're great research projects and tell us a lot about drugs and really have told us most of what we know about psoriasis medications, including more new treatments like biologic treatments, which are very effective for psoriasis. So they're really great. But nonetheless, nothing is perfect in this world. And for those who have participated in clinical trials, know they're pretty strict. They're very regimented. The selection criteria, there's multiple different criteria you need to meet, or criterion you need to meet to get into one of these trials. You need to keep attending, and they're pretty controlled. So it's a little bit like testing the performance of a car and knowing, what's the miles per gallon. So this is a picture of one of these cars tested for the WLTP range. And I don't know what cars people take or drive, but often we know that those estimates are pretty optimistic. I drive an electric vehicle that often don't really perform to what they tell us. Same with petrol or diesel cars. And that's because they're tested under very strict conditions, like in that photo there. If you look on the other photo, perhaps that's more typical of the kind of conditions that we would experience if we were to drive from Manchester out today. And for those of you who've driven into Manchester or are from Manchester, this might be a familiar sight to you at night on the Mancunian Way, stuck in traffic with a bit of rain. So you can imagine that the performance of the cars would be quite different in that real-world condition compared to the very controlled setting in the lab. Just to draw another potential problem with clinical trials, they also only include a snapshot. There's only a small group of participants, even if it's hundreds or even thousands, that's still a small group of participants compared to everybody who has psoriasis. And it's a little bit like taking a snapshot like this one. So if you look at this photo from a recent match between 2 big teams in Manchester, one in blue, one in red, you might think, it's a bit worrying. There's lots of police. Thank you. There's a lot of police. What's happening? If we just take the snapshot, you might be quite worried that might be something going on. But if you zoom out, it could be a normal match, albeit still with some problems in small areas. But sorry to bring up some bad memories for those in certain colors, but it could be a perfectly normal match. So zooming out, being generalizable, knowing all the full picture is also really important for us to understand the effect of drugs for psoriasis. So we all know a lot about medications for psoriasis. So we're going to concentrate on biologic therapies, and we all know that these are really effective. They've really changed lives for many patients around the world, and especially in the UK as well. What we might not all know is that these are big molecules. These are complex molecules. So that's an example of a biologic molecule that's much larger than what you expect, with a similar biologic, insulin, quite small, and then aspirin, a common drug, much smaller still. So they're quite complex. It's really important to understand the effects of these drugs outside of these controlled populations. And to do this, one of the ways we can do this is to really collect data from a lot of people around the country. And this is essentially this project BADBIR, British Association of Dermatologists, Biologics and Immunomodulators Register, or BADBIR. Really important, we're including data from around the UK. Lots of different centers, lots of registrations, patients on different medications, biologics, conventionals, smaller molecules, and really collecting lots of data over lots of follow-up to get that big picture understanding of effect of drugs. So everybody in BADBIR would be followed up over time, 6 months, a year, 2 years, 3 years, to really understand long-term effects of medications, to really educate patients and clinicians on how we should use these drugs going forward as well. Would just like to flag a new initiative within BADBIR before I go on to results. We recently started something called a patient portal. Really helpful for us in BADBIR, but also helpful for patients to put their own data onto the portal so that we can really get a better understanding of that snapshot when you go to clinic, but also in between the times, so that we know what's going on with psoriasis, and it really helps us get that better understanding overall. And it's really kicking off. We're getting a lot of registrations, really taking a lot more data to try and understand our effects of drugs. So moving quickly on to some of our results. I'm going to break this down. First of all, looking at the effect of treatments, and then looking at safety of treatments. There's going to be a lot of figures and numbers, so I'll try and break that down bit by bit, and hopefully I'll be able to convey to you a lot of the work that's been done by multiple members of our team. So first of all, we're not only interested in biologics, we also have data on the more traditional drugs like methotrexate that was described earlier. And this is some of our work led by research associate Oras Alibes, looking at the effect of more traditional drugs outside of those trial settings. We've heard a little bit about methotrexate already. We can see that this is looking at outcomes of PASI, looking at people who have PASI of 2 or below, or 4 or below. And you can see that methotrexate performs pretty well when compared to the other treatments such as acitretin, cyclosporin, and much of this is fumiderm, which is an older drug as well. They all perform not to the highest standards, but methotrexate and cyclosporin do particularly well. And then if we look at a more less stringent outcome of PASI less than 4, again, our patients do quite well on methotrexate and cyclosporin, and less well on acitretin. So this is giving us a bit more of a flavor of what is really happening in real life, or in the real world rather, on these drugs. So you're going to look at a couple of these graphs today. Essentially, these are graphs showing retention on treatments. And essentially, the steeper the curve, the less good the retention is, so that the worse the drug is performing. And what RS has done here is to split it by the reason of discontinuation. So you can, mostly the two main things you would discontinue a treatment for is either the treatment's not working as well as it should do, or it's giving an adverse effect or a problem or side effect. And when we split by these two reasons, we can come up with a bit more granularity, a bit more understanding of what's happening. So here, this is looking at treatment effect. And so you can see that acitretin is the steepest, so a lot of people are discontinuing. And the other treatments are less and around the same. So actually, people are continuing on these treatments. Sorry, you can see now there's a lot of these curves coming your way. Really kind of pretty similar. But when we look at discontinuation due to a side effect, then you can see a bit more of a split. Methotrexate seems to be tolerated pretty well. Acitretin, although it doesn't work so well, is tolerated pretty well. And then cyclosporin and fumaric acid esters come afterwards. So people get a little bit more side effects from those. What I would say is all of those aren't too bad. Those slopes aren't looking too bad. So there's still a big proportion of patients doing quite well on these more traditional treatments. So Oras, what she then proceeded to do is to compare against a newer treatment, the Biologic. So here, she compared methotrexate to adalimumab, which is a TNF inhibitor, one of the biologics. Unsurprisingly, the Biologic really performed better, really reflecting what we already know from trials as well. But it's good to get that reflection. So when she looked at the PASI level, she did find that people achieved a higher proportion of patients which achieved a good outcome on adalimumab. Again, not unexpected, but good to see that it's reflected in our bigger population. Again, a similar graph. The steeper the curve, the worse the treatment is. For both of these outcomes, adverse effects and treatment effect, you can see that adalimumab outperforms methotrexate. Again, showing that these biologics are making a difference to treatment effect for patients. Okay, so we're comparing head to head. What about putting these together? If you're on adalimumab and it's not working so well, should you actually consider adding methotrexate or starting from both together? And this is some work that I led on to really try and use this data to try and understand whether adding methotrexate is a good idea. So again, slope, the more steep it is, the worse the treatment outcome. We have two slopes here. One is in blue, and those are people only on adalimumab. The slopes in orange are people with adalimumab as well as methotrexate. And you can see the shaded areas, which is the kind of the level of uncertainty, these two slopes cover each other, really showing that in this big data set, we really haven't got good evidence that adding methotrexate benefits patients on adalimumab. Now, there is some uncertainty baked into it. You can see there's quite a wide area for orange, and that's telling us that we don't have that many patients here. So there's still a question mark around this. But it's good to know that if you are at the situation where the adalimumab isn't working so well, there may be better options out there than adding one of these more traditional tablets on. So then, let's look a bit more contemporary now. We know that it's not just adalimumab we've got a lot of other biologics that work even better. And what we did here is to now compare against more new treatments. And these are treatments such as gazelkumab and risankizumab. These are the interleukin-23 inhibitors, a bit newer, works a bit better. And also the interleukin-17 inhibitors, ixekizumab, secukinumab, and brodalumab. These are also second-generation type biologics. And many of you might have heard about these treatments and also been on these treatments. What we don't really have is that real-world evidence just yet, and that's what we aim to try and understand in this particular graph. again, steeper the curve, the worse the treatment is. This is about overall retention rates, and you can see that the interleukin-23 inhibitors do quite well. So these are the ones in dark brown and orange. That's guselkumab and risankizumab, pretty similar, no real difference there. We've got ustekinumab, an older treatment, along with ixekizumab. Retention rates are quite similar. And then those other 3 treatments clustered together. So they're pretty similar, looking at the retention rates. So this is another way of looking at treatment effect outside of things like the psoriasis area severity index, the PASI, which gives us a good idea of how well patients are finding the tolerability of these treatments in the real world. And what we did to try and compare and give easier comparisons when we're trying to decide against each other is we just calculated the area under these curves and then compared the lines to each other. And essentially, these are what we're doing. You can ignore the numbers because we have got lots of biologics here. You can look at the colors. And so we're comparing the left treatment against the right treatment. And when you have a green color, that means the left is better than the right. The red means the right is better than the left. And you can see, essentially, when you compare the interleukin-23s, against each other and also against the other treatments, they tend to outperform the other treatments. So we know that patients stay on these treatments a bit longer than most of the other treatments. And again, for safety, they tend to do pretty well. So moving now back to the older drugs and the other biologics, can we try and use these drugs a little bit better? And one interesting idea that some other specialties, such as gastroenterologists, have used is to try and measure the drug level and see whether or not that can tell us something about how well we can use this drug. And some work performed mostly from King's College London, as well as our other partners, have looked at therapeutic drug monitoring. Can we predict outcomes going forwards? And in some work done by Nick Dannon and his colleagues, they found that there's a target drug level of 7 micrograms per milliliter, essentially just a level after which, the probability of response going forwards in time is quite high. And so this is now educating some clinics to try and understand if we take the drug level when it's very steady, can we predict what happens afterwards? Should we continue with adalimumab after this time, or should we think about switching to some of the other treatments? And that's really helping us better use the tools at our disposal. So we've finished on treatment effect, and let's look at second part of treatment effect or treatment tolerability. That's adherence. And we know quite a lot of about adherence from other literature. We know, for example, patients tend to adhere a little bit better to injections, maybe slightly worse to tablets, and then maybe slightly worse still to creams. And what Rachel Thornlow did in the IMAP study is to have an embedded nested study within BADBIR, collecting data from some patients. This is a couple of years ago now, and trying to understand not just adherence, but also why, the factors associated with adherence, and also understanding some behavioral and psychological predictors of treatment response. You may have heard about some of this data before. So she looked at this new data and combined it with some of the usual data we collected in BADBIR, including demographic data and clinical data. So what she found was, in all, pretty reflective of what we know. Generally speaking, biologics being injections, they tend to do a little bit better than in terms of adherent levels compared to tablet treatment. She also broke it down by intentional and unintentional adherence. So unintentional would mean somebody like me who might, I know that I have to take that tablet in the morning, but I just had to rush to work, so I forgot. And so I missed my tablet in the morning, I took it back in the afternoon. Intentional adherence means, oh, actually, I'm not really sure about this, although I heard about this tablet in the clinic, I've got it now, but looking at the side effect profile, it's not really for me. and then put it down. So she's broken it down into these 2 types of adherence. And you can see the levels are a little bit different, but overall, again, the tablets are a little bit higher compared to the injections. And she then broke it down by the different types of treatment. Cyclosporin, there's a really high level of non-adherence. The injections are a bit lower, but you can see that etanercept, which is not used that much these days, has a bit higher non-adherence compared to adalimumab. What she did then is to take that data from the background behavioral medication belief and try and understand a bit more. And from her score, she broke it down into 3 groups. So there are 3 different groups of how you would consider medication. There's one group, group 1. These are people who are pretty concerned about their treatment, so that they're not really happy with the background in terms of side effects and how the treatments work. Group 2 is in between, so they're a bit concerned about side effects and maybe about overuse. They don't really want to use medications for a long time if you can avoid it. And group 3 are people who are more happy to use treatments over long term. And what she found was pretty understandably that patients who had stronger concerns about therapy would discontinue a bit more, so about twice as much as other people. But that was not the only reason. So she also found, as we've looked at, patients on more traditional tablets had a 4-fold increase in the possibility of being associated with non-adherence. There's also the effect of age with an inverse kind of relationship, which is, again, I think expected, and also the longer you've had the treatment, the more likely you are to stop using it. So now we're going to pivot on to some of the safety outcomes, which is really the core idea, core reason why BADBIR was set up, to try and understand the safety of these newer biologics. And some of this is back from collecting data from 2007 until now. Some of my older work on serious infection, when we looked at the adalimumab, etanercept, and ustekinumab, some of the older, more established biologics for psoriasis, we compared the risk of infection against a group of patients on a collection of tablet treatment. We found no real difference, no significant difference in the risk of serious infection. These are infections that have a significant consequence, admission to hospital with an IV drip, and so on. So this is really reassuring back in the day. And then when we looked at infliximab, we know infliximab is used pretty differently. You need a higher disease threshold to get onto infliximab, and it's also a bit more of an ordeal. You need to go to hospital for a drip. And we found that there was an effect, so that was associated with a 2 to 3 times increase in the risk of serious infection when compared to non-biologics. Now, we now have newer treatments, and with Heber's talk that's coming afterwards, one of my PhD students, he's going to now start to expand that and look at the newer treatments to compare those to the older treatments as well as to the more traditional tablet treatments as well, to see if this has changed over time. One new side effect that some patients and doctors have noticed is some people can get what we call paradoxical reactions, in which patients who don't have a rash get a rash, and patients who have psoriasis get a rash that looks more like eczema and doesn't look like their usual psoriasis. And we're starting to see more and more of this side effect. And what Ali Al-Janabi did, he's a PhD student and now an ACL, a clinical lecturer within our group, has started to look at is trying to define it, trying to understand this rare side effect and see what is happening. And one thing he did was to look into BADBIR and just kind of try and quantify the level of how often this is occurring. And you can see that he's plotted this across time. So this is looking, if you're looking across your right, the more right you're looking, the further across in time you're getting. And as with many side effects, they tend to happen when you first start the medication. So most of these cases of the emerging eczema is starting across within the first year of starting the medication. And so this is telling us a little bit something about how we would expect if this emerges, is this likely to be this particular outcome. He then tried to look at other factors, including the actual treatment type that was associated, and found that actually, again, interleukin-23s tend to do quite well. So they were associated with a bit lower risk compared to the more traditional TNF inhibitors, the adalimumab, in terms of causing this odd rash. And he also found that people who had a history of atopy, this is things like hay fever, asthma, or eczema to start with, tend to get more of these particular rashes. So this is really helping us. And then what Ali is doing as well is he's doing more work in teasing into the genetics and other biological factors of whether we can try and understand this a bit more, tease this out a bit more to try and understand what is going on. So look out for his talks in the future as well. So there's going to be a lot more on safety of treatments, and Ben, who's talking after me, is going to talk particularly about safety of biosimilars as well. So I'll leave him to talk about that particular area. I'm going to pivot on to future studies now, and what you would expect to hear from us in the next year to 5 years' time. I'm going to start off with my own study, and this is really not a specific psoriasis study, but we are looking at psoriasis as well. And so this is pivoting back to the first point about the difference in the real world, what we expect in unselected patients with psoriasis compared to trials. I wanted to really know whether the data that we come up with in the general population, the general psoriasis population, is reliable. And this project aims to try and understand and tease this out a bit more, not only in psoriasis, but over different types of conditions, including rheumatoid arthritis, eczema, lupus, and so on. And this big project is trying to understand whether we can reliably reproduce outcomes from trials. We know that trials are very robust, although they only have a small sample of patients. So whether we can use techniques to try and mimic trials and try and come up with the same answer, because we now have the right answer, and try and identify some areas where if this doesn't reliably replicate what is going on, can we make our results more reliable going forwards with analytical techniques? We also want to know about subgroup effects, and it's sometimes very difficult. We all have suspicions about, actually, we feel that patients with this particular characteristic might respond better to this drug or that drug, but often we don't have the data to look at this. And what I want to do is to look not only at trial data, but also at this bigger data set and look across these different data sets and different diseases to come up with questions like, does female sex respond differently to particular drugs? Do people who are older respond differently to different drugs? And across a whole range of these different characteristics to try and better understand, can we better use these medicines? We then try, the third part of this project is try to then take our results from trials and transport it to the real world. Is there a difference if we take a trial result comparing one drug to another and then take it to a population and weight it so that it looks more like our real world population? Does that make a difference in how we interpret what is the better treatment outcome? And then the fourth part of this project is to try and predict what's going on. Can we really reliably rely on this type of data, and can it actually predict trials that's ongoing and really a proof that this can work? And I've started to do a little bit of work on this. So this is a clear study which compares secukinumab against ustekinumab. This is a forest plot. So with forest plots, you might, sorry. I don't know if that's a timing for me. I'm going to end soon, so don't worry. So basically, in a forest plot, you have the line of no difference, which is here. So any line that touches that line is telling you there's no difference. You have this side, which favors secukinumab, this side, which favors ustekinumab. So the dots is what we think the treatment effect is. So any dots on this side is saying secukinumab is a bit better. This is what we find from the trial. can see that it's on that side, so they found secukinumab is a bit better than ustekinumab. The line is the uncertainty. How uncertain are we? So possibly the treatment effect is between here and here, and this is the risk difference. So this is what is the proportion of different patients between the two groups that are responding to the drug. And here are the different types of methodology. You can ignore this side because these are all just methodological names. Essentially, we're looking at how close we can get the dots and the lines aligned. And you can see that we're doing pretty well for some of these methods. And this is just for one comparison. What we want to do in this next stage is to compare against lots of different comparisons and try and understand how we can do this better. So that was my study, and if you're interested, please contact me. I'm really interested to hear from different people, patients, clinicians, other researchers, to see how we can do this better and include more perspectives. So please contact me if you're interested in that particular study. But here is a list of all the things that are happening going forwards. And you can see that we've got lots of different studies happening. We've got some safety studies. COVID potentially is a bit, hopefully, we've passed that now, but we want to learn from our experiences. And Oras Alibis from Manchester is leading on this work to understand the effect of biologics. What we know is biologics are pretty safe. They don't really affect the risks of COVID and bad outcomes. But we want to look at more data to try and confirm that. Brian Kirby from Dublin is wanting to look at safety of adding methotrexate to adalimumab, so he's leading on that study. Phil Hampton is leading a really important study to understand pregnancy outcomes with biologics. Ahmed Hawa from Manchester is looking at the risk of nervous system disorders such as multiple sclerosis and the risk associated with biologics. Nick Reynolds is leading on a couple of studies using more sophisticated AI techniques to try and understand safety of medications and also outcomes as well. And he's got a PhD student, Amani Hussain, who's looking at using AI to predict biologic outcome. And then also a couple of other important studies, really important to generate some outcomes and understand the effect and safety of treatments in our pediatric population. That's led from Oxford. We're increasingly trying to understand the impact of health disparities on treatment outcomes, and Layla is leading from Manchester to look at some of our data as well. And then we're all really interested in trying to learn about whether we can modify the onset of psoriatic arthritis, and Oras Alibis, again from Manchester, is looking at some of our data on emerging psoriatic arthritis. So lots going on, hopefully much more to share with you in terms of our research outcomes in the following years. So with that, I'd just like to acknowledge the team. It's a big project, lots of people involved. We've got lots of people working in the steering group and also a great team working in Manchester, really dealing with the queries from clinicians, trying to nail down those safety events, making sure they're genuine, getting those data from the team. And this project won't happen without this big team. This is slightly outdated now, so Danielle is now the study manager. So she's someone, I don't know if she's here, but she'll be around in different conferences and also available to speak to any interested clinician or patient about this project. And all the different centers. We have lots of different centers, different people contributing data, patients, clinicians, nurses. We can't do any of this work without them. So this is a snapshot of some of the highest recruiting centers over the couple of months. And then this is a list of all the different centers and all the investigators involved. So thank you very much for your attention. Thank you to everyone who's participated in the room in this project. And I'm happy to answer any questions going forward.
Thank you very much, Zenas, for that very thorough update on the BADBIR work and mentioning yet another PhD student that we've funded that is looking at the eczema in biologics. I think Helen sent me a slip of paper to say we funded that one as well, so that's great. I've got a couple of questions I wanted to ask you about. I was really interested in this 45% cyclosporin non-adherence figure, and I wondered how we explain that. That was number one. And the second thing is, you were quite dismissive. You just said you expect younger aged patients to be less adherent and more challenging, and I just thought I might pick you up on that and see whether you could explain and answer those two questions. Thank you.
So I caveat that this project was led a couple of years ago by Rachel Thornlow, who was a patient. Actually, she might be also supported by Psoriasis Association, so I missed that part as well. It's the cyclosporin aspect. I think a lot of this work has really flagged the importance of intentional non-adherence, how clinicians have gone about explaining side effects from the beginning, consenting patients. And I think this theme will also come with biosimilars as well. I think a lot of work has drawn out the fact that actually patients don't have enough time in clinic. Clinicians haven't really gone through and really dealt with the concerns and expectations and the beliefs of patients and drawn those out to try and discuss them before going towards prescribing a medication. And I think that's a strong factor that she's found, that's intentional non-adherence that we can do better as clinicians to explain to patients. And because cyclosporin, if you read the leaflet, it is pretty long in terms of the side effects. Quite like a lot of drugs we use, but also associated with a lot of side effects that sometimes can happen. So I think it is not surprising, but it is good to look at these figures. But of course, this is a snapshot in a particular project, so we need to look also at the other research projects going forward. And that relates to the second point. I think perhaps I was a bit dismissive of that young population. I'm kind of classifying myself as a young population, but maybe I'm not. But in the literature, there's a lot of work that's telling us that people, especially between 20s and 40s, who have multiple responsibilities, going through university, starting work, starting a family, that can really impact on how people adhere to medications, and perhaps that's more non-intentional adherence. So from the literature, that proportion of patients, those tend to have higher rates of non-adherence. When you start to become to retirement age, you tend to get a little bit better adherence to the medication, and that's across different medications. But absolutely, I think we can't just tar everyone with the same brush. We need to continue to look at our data, continue to do more research to try and tease these things apart, to try and get this better. Yeah.
Hello. I noticed that my consultant's name was up on the board, so I'm really pleased about that. And when I've been using Solara since 2013 and was very nervous before I went onto the medication, but I think for me it was my consultant and the way I trusted my consultant and the way she interacted with me, and I still do. And so I can't understand it all. I'm just a patient in a sense, but I think that's really, really important that your consultant understands you and explains. And I just said to her, am I at more risk to go on the medication or to stay without it? And without hesitation, she said, you are more at risk to not have the medication. And she stuck by me, and I feel very comfortable with her. So I don't worry too much about all the other things because I know she'll pick them up. So, but I don't know how that she participates with my information because as far as I'm concerned, I don't know. Do consultants just go by their own information, or do they ask patients? Because I've never been asked, but she obviously is part of BADBIR. But thank you for your talk.
Thank you. That's really lovely to hear, and I'm so glad that you have that really great experience with your consultant. And I think it's really key having that relationship with your consultant or any healthcare professional looking after you, so you feel comfortable if you have questions to go to them. And I think the work that we're doing here is giving them more information, ammunition, and understanding so that if you have a question, they can also go to some of our data to try and really have that backup of explaining this is what is happening in the UK population. And it's great that your consultant is within BADBIR. Sometimes it's a bit of a quirk of the project as well, because there are different times when there's different medications being recruited. So because if you are not aware you're in this project, you won't be, because all patients are asked for their consent, and the team will double check and keep on top of that and make sure that the consent is there every time they collect data. So it definitely won't be in there, but it might just be because of timing or other things that you are not in there.
Dr. Yiu, thank you so much for that enlightening talk. I'm Weiss Hader from Bristol Myers Squibb. Just given the data you presented, following on from Dr. Schofield's question around cyclosporin, but also the other conventional systemics, and also the effectiveness and the reduced drop-off from some of the biologics that we have today, where do you see the future of conventional systemics, particularly because when you think about drugs like methotrexate that we give to patients, and we think about a significant proportion of patients that don't clinically respond, but actually there is a theory that we are affecting their immune system in one way or another, and that might affect their response to other drugs later. We can't kind of demonstrate that really. So what is the future of conventional systemics going forward?
Yeah, it's a really good question, and a thought that is echoed by many patients and clinicians in the field. Can we use our treatments a bit better? How can we make sure that we ensure the best long-term outcome for our patients? I think definitely the jury is still out. In this country, we do need to think also about the cost of medications and the cost effectiveness of medications. So that is one factor. You will hear in the next talk about biosimilars, and that is an emerging field that is changing the question of cost going forward. And I think that will have an impact on this question about where best can we use these treatments. Can we use better treatments earlier? I'm involved in a couple of research teams to try and get a better understanding of this. So Phil Hampton from Newcastle was really interested in this, wanting to know whether or not we can use biosimilar adalimumab a bit early on and not have to wait until the disease is a bit more severe, which doesn't make sense to anybody. But we do need to generate data, and it can be quite difficult to prove disease modification or disease kind of sequential treatment on modification. But this is something we are interested in.
Super. That's really, really good to hear, actually, because in terms of the cost, absolutely agree with you. I moved to industry 2 years ago, but my background is in general practice and the NHS for the last 14, 15 years. So I do understand that element of it. But I also think that when you look at the steep curves that you described for the conventional systemics, you think about the number of hospital touch points, community touch points, healthcare resource use within that patient population. And if you look over a longer term, are we getting less? And I just think that's what we're guilty of within the NHS at the moment. We're looking very, very short term rather than a longer view, not just from an economic perspective, but from a patient perspective too. The number of patient touch points is not just detrimental for the system, but actually for patients in their lives. So it's a great piece of work, and I'd love to see this in the future sort of take effect and move forward. Thank you.
I think this is a debate which could probably extend to encompass a conference on its own. So I think we'll need to draw a line there and move on. But thank you so much for that, Zenas. It's a wonderful presentation, and I think reminds us all that although biologics have, if you like, revolutionized treatment, our use and understanding of them is still very much something that is developing, and you've given us a whistle-stop tour through that. So thank you.
Thank you.